Hey guys, so today we're going to talk a little bit about renal tumors and some general information about how to approach them and how to distinguish between the different types of neoplasms that we can find in the renal parenchyma. To start, let me say that there are going to be four basic categories or descriptors that we want to look at when we see a lesion in the kidney. And as in this case, we're seeing a hypodense lesion here, exophytic. That's how I'll describe it. So exophytic hypodense lesion. In this one, this axial section, we don't appreciate the exophytic component as well as on the other coronal ones. But the main thing we need to start asking once we see a lesion like this is whether this is a cyst or a solid lesion. And after that, we can ask whether it's infiltrating or not infiltrating the renal parenchyma, whether it's hypo or hyper dense. Since we're talking about CTs, we're going to be referring about hypo and hyper density as opposed to hypo and hyper intensity when we're talking about MRI. The other category and the fourth one is going to be the fatty versus soft tissue component. So that's how we're going to approach these in terms of the intensity. So let's take this case here, assuming we're on the radiology station, the PACS, where we can measure Hounsfield units. We should be able to measure this and get an idea that this is going to be a cystic lesion. We're going to if we're looking for a renal cell carcinoma, the main thing that we're going to have is different phases so that we can assess how this lesion is enhancing, okay? And we're going to talk a little bit more about what defines enhancement. But that's pretty much what we need to do at this point. Another thing that we tend to describe whether this appears as a ball that's growing from the kidney and distorting the renal parenchyma versus the bean shape, which is the normal configuration of the reniform shape or bean shape of the renal parenchyma. That being said, we move on to what we call renal cell carcinoma, and it's important to know that as far as ultrasound goes, the renal cell carcinoma can really have any appearance. So although we might be more or less suspicious depending on what we see on the renal parenchyma, we cannot really exclude a renal cell carcinoma based on the appearance in ultrasound. As far as CT goes, we have two main phases that we're gonna want to know and distinguish between the cortical medullary phase and the nephrogenic phase. And the take-home message here is that nephrogenic phase is the most sensitive phase. And I'll give you an example about how the nephrographic phase is going to be the more sensitive one. Moving on, so we have another example. In this case, is going to be a renal cell carcinoma. And going back to the enhancement, so we define enhancement as more than 15 units or 15 Hounsfield units, an increase of an absolute increase of 15. So we're going to compare our pre-contrast examination with our post-contrast examination and measure in Hounsfield units that difference. And that difference is going to make us suspicious that this is going to be a vascular tumor, and RCC is known to be a very vascular tumor. That being said, another part of this would be measuring the washout or the de-enhancement. Also, some people say that if we get from a arterial phase to a delay phase, if we get a de-enhancement of 15 units, 15 Hounsfield units, we can more or less make the same conclusion. However, there's a caveat about this because you might be getting your enhancement, your baseline enhancement might not be at its peak. So the real washout or the de-enhancement that you're getting is not a real value. So you might be underestimating the washout based on this measurement. So I really don't advocate using this technique. I would feel more comfortable definitely going with a pre-contrast exam and a post-contrast exam and measuring that density so that way you're sure you're not missing an important diagnosis here. As far as MRI goes, we use percentage of enhancement, but it's pretty much, it's a slightly different formula based on signal intensity, but it's also going to be 15%. That's going to be the measurement we're going to use. Another point I wanted to make about RCCs is that they're all going to be adenocarcinomas, namely they're going to be coming from the epithelium, But the difference between the different types of renal cell carcinomas, it's more of a histologic and pathologic diagnosis. We do need to know them, but bear in mind that this is distinguished. This is going to be something they're going to distinguish under the microscope. Okay, that distinction is going to be made under the microscope. That being said, we have three main ones that we're going to be assessing, and that's the clear cell, the papillary, and the chromophobe. And we need to know, there are more than this, but we need to know these three because they're going to be the main ones and the ones that we're going to find most commonly when we're assessing CTs. In terms of the clear cell carcinoma, we know that we're going to be able to see it better in the nephrographic phase. And as we said before, we mentioned that the nephrographic phase is going to be the most sensitive phase. As far as papillary carcinoma, we know that since the nephrographic phase is more sensitive, we're going to see it there. But also because it doesn't tend to be as vascular as a regular clear cell carcinoma, the papillary one, we're going to be able to see it on the corticomedullary phase. So that's an earlier phase, and since that phase, we're already seeing something that makes us suspicious for a renal mass, and that's going to be most likely a papillary type of carcinoma. And that's one of the reasons, based on those factors, we can start getting more knowledge about the histology that's going to be the final result for this tumor. So in terms of vascularity, we'll rank the clear cell as being the most vascular one, the papillary as being the second most vascular one, and then the chromophobe, which is another type, and this one's going to be less vascular. Although we're not talking a lot about MRI here, bear in mind that we're going to have basic sequences that we want to include in our protocol, and that's going to be a T1 with and without contrast, a T2, and obviously a post-contrast T1, but it's going to be 3 phases. Additionally, something that's important to know is that T2 brightness in a renal lesion that's suspicious needs to be further evaluated with a dedicated renal mass protocol. So this is something that we often see when we're doing lumbar spine MRIs or some other type of study that let us see the kidneys and we see a T2 brightness. If it's not really entirely homogeneous, we cannot just assume that it's going to be a cyst because it's T2 bright. So that's something to have in mind. So that being said, this is an example of a renal cell carcinoma once it's removed. So we have the renal parenchyma, the cortex here, and we have this mass kind of distorting the cortex, and that's an example of gross pathology. Finally, we have another example here. This is going to be an oncocytoma. Although the oncocytoma, we're not able to really distinguish it based on imaging, so most of the time it's still going to come out, although it's a benign lesion. Bear in mind that there's some pathology of renal tumors that are going to be benign, but we're just not able to distinguish them on imaging, so we cannot risk having the patient not undergo surgery. So that diagnosis is confirmed under the microscope as well. These lesions, we see kind of like fat density, smaller lesions, and this is going to be classic for angiomyolipoma. They're usually going to be fat containing. They're not necessarily going to be this small. It's particularly important to know that once they get bigger, it is important because they have a significant risk of hemorrhage, and this can be treated by interventional radiology with endovascular techniques. So that's something to have in mind. Okay, guys, so that was a basic review of renal tumors, and we're going to keep adding more information on these as we go on. Thank you.